be presenting to us today all about sleep. So I'm going to go ahead and share just a couple of things before I turn it over to Dr. Biscardi. And the first one is a quick reminder of our next Wellness at Work webinar. That is going to be on November 19th, and the topic is diabetes. So when I send you your update about today's presentation and your Personify Health voucher code, I will share a registration link so you can go ahead and get registered for that webinar coming up on November the 19th. Also, I want to remind you, you're probably already using Personify Health, hopefully on a regular basis, but you're going to hear a lot of great information today from Dr. Biscardi. But Personify Health has so many different ways to support your sleep health. I found at least 4 different journeys, one of them that deals with shift worker sleep. In the media tab, where you can watch videos and webinars, I saw at least 7 different media items that are directly related to sleep. And if you go in and set your topics of interest so that you'll see things that you're interested in learning more about, there are lots of topics of interest directly related to sleep. So I just want to remind you, utilize that Personify Health app. I tell people you're scrolling, most of us are scrolling at some point throughout the day. Take the time to log on to your Personify Health. It'll be the best minutes of scrolling that you'll do in your entire day. So I love to see the comments. Thank you all for supporting, and thank you for taking the journeys. Absolutely. All right. So at this point, I'm going to go ahead and turn it over to Dr. Biscardi, who is going to give us an overview of sleep and sleep disorders. Thank you so much for being here, Dr. Biscardi.
Oh, I thank you very much for asking me to participate, and I'm very happy to see so many people listening in and from all across the institution and all the different.
Dr. Biscardi, can you unmute?
Oh, hello. Can you hear me now? Can you hear me now? Hello? Okay. So I'd like to thank you all for your attention today and coming. I see there's so many people from across the institution, and we're going to talk about a lot of things today, maybe too many, but I'll try not to go too fast. I'm here at the Sleep Disorder Center at Carilion, and I also go out to Stonewall Jackson, Rockbridge Community Hospital, and work with my colleagues across a lot of the different sleep centers in the area. So what is sleep? Well, it's not really turning your brain off. It is a usually intentional, reversible behavioral state where you kind of just get disengaged from the environment. You don't respond to things. A lot of things biochemically happen in the brain. And it's not really a time of brain silence. It's a time where there's a lot of activity, particularly in rapid eye movement sleep, which we'll talk about. So why do we fall asleep when we fall asleep? Well, it's a function of 2 things. One is sleep pressure, which is basically how long it's been since you last slept. The more you're awake, the more you're likely to go to sleep. And the other thing that promotes sleep onset is where you are in your circadian rhythm for sleep. So circa in Latin means about, diem means day. These are rhythms that are 25 hours long, which is about a day long, so we call it a circadian rhythm. And there's all sorts of different circadian rhythms, and these are run by your thalamus. And there are things that you need to maintain and do, but you don't have to really think about it. And your thalamus regulates your body temperature, growth hormone, cortisol. There's a whole lot of different things, blood pressure. And what we see in the course of a 24-hour day, this is military time, is that your body temperature goes up and down roughly twice a day. And interestingly, you only will fall asleep when your body temperature is falling. Isn't that odd? Okay. And body temperature, this is just 1 degree Celsius, so it's not a huge change in your body temperature. But you'll only fall asleep when your body temperature is dropping, and you'll only wake up when it's rising. Now, if for some reason this curve gets moved forward or backwards, we sometimes have problems with sleep onset. And people have these rhythms and they last for a long time and they move very slowly one way or another under certain pressures. What are the things that tend to change these rhythms? The researchers, I think were German, they call them Zeitgebers. Zeit is from the word time, and geben is the verb to give. So Zeitgebers are things that give you a sense of time. And they're basically light exposure, meal times, and exercise. The strongest influencer of all is light. Light strikes certain particular non-vision receptors that are specific for light in the back of the retina, and they send tracks to the hypothalamus, which is where your biologic clock is. And these things can move the circadian rhythm curves forward or backward. Interestingly, for those in nursing, you lose a lot of these in hospitalized patients, particularly in the ICU, where it's always dark and there's no activity and people are NPO. And then you have people who never really sleep and people who are never really awake, and it leads to medication to make people sleep, which leads to more confusion and delirium. And this is a big this, in my opinion, is a driver of ICU delirium. We did a little paper about that here at RMH. So once you get to sleep, sleep is divided into two types of sleep: non-rapid eye movement sleep and rapid eye movement sleep. And if you have a puppy dog or a cat, they get these two, and you can actually see the eyes moving rapidly in certain periods of their sleep. They may actually twitch as well. And these are biologically very different types of sleep. And to sleep well, you have to go through all the different stages of sleep, and there's 4 of them. And you have to go through them in a particular order to really sleep well and feel rested. The different stages of sleep, I won't go into too much about this, but the lighter stages of sleep is stage 1 sleep, and it's hard to even tell if you're asleep. This is that little drowsy thing you get on the interstate when you really should have pulled over a while ago, and you're sort of drifting in and out of sleep. It's very easy to get woken up out of it. Stage 4 sleep is very hard to get woken up out of, and it's more common in young children. And some of you might have tried to wake up infants at times when they're in the stage of sleep, and you can shake them and talk to them and do whatever you like, and they won't wake up. So REM sleep is typified by paralysis. You become paralyzed when you're in rapid eye movement sleep, which is the stage of sleep where you're dreaming. And in general, most dreaming occurs in rapid eye movement sleep. And the good Lord decided to turn off all your muscles so you don't act out your dreams while you're sleeping, and you develop atomy or muscle weakness. It's a very interesting part of sleep. The brain's highly activated, and if you look at the EEG, it looks very much like an awake EEG. And you'll have bursts of rapid eye movement, which is part of the mechanism of this. When this was first discovered by William Dement, excuse me, no one really understood what REM sleep did. So he did this experiment where he just had volunteers sleep in the sleep lab with a technician next to him, and every time they went into rapid eye movement sleep, which you can pick up from a polysomnogram, he woke the patient up. And after about 2 weeks, they almost got psychotic. So REM sleep is very important for sort of reconditioning your brain, so to speak, while you're sleeping. Sleep normally is divided in different stages. Some of this is age dependent. You spend very little time in the lighter stages of sleep, most of it in stage 2 sleep, and about 20% of your night in REM sleep. As you get older, this diminishes and you have more of the lighter stages of sleep, and you tend to spend more time in bed awake, and sleep changes as we get older, unfortunately. Most of the rapid eye movement sleeps in the later part of the night. That's why you typically dream around morning time. How much sleep do you need? It varies depending on age. Those of you who had little children know that infants sleep almost all day long. And adolescents in particular need a lot of sleep. As you get older, you need less sleep. And some of this varies. Some people are constitutional short sleepers and just don't sleep that much and they feel fine. Other people have to sleep 9 hours a day or they feel badly. Thomas Edison only slept 1 hour a night. Napoleon only slept an hour a night. When you don't get enough sleep or your sleep isn't very good, you end up getting excessive daytime sleepiness. And this is the inability to remain fully alert or to go to sleep easily during the day. And it's a function of how long it's been since you last slept and where you are on that circadian rhythm. So as you all know, late in the afternoon, around after lunch and to about 4 o'clock, one gets very drowsy. It's got nothing to do with lunch. It's just that your body temperature is dropping, and that's your circadian rhythm telling you that maybe you ought to take a nap. In Italy, at lunchtime, everybody eats a big lunch and sleeps for an hour or two, and they go back and work till about 7 at night. And it's a delightful way to live. Can't do it here in the States, but the excessive daytime sleepiness is really a function of clock time. You're least awake around 4 in the morning, and you're most awake around 11 in the morning. You can really, so people who are excessively sleepy tend to fall asleep faster than others, and you can quantitate this. And you might say, well, how can you precisely tell when someone falls asleep? You can look at them and not really know. Their eyes are shut, but they could be awake. Well, you can look at the electroencephalogram. This is part of a polysomnogram that we do in the sleep lab. And this is 8 cycles per second, alpha, and it stops right here, boom, and the patient is asleep. So it's a very objective thing, and you can measure it and measure excessive sleepiness. If you want to do it subjectively, which is a lot easier, you can use the Epworth Sleepiness Scale. This is often part of a clinical assessment of sleepiness. It doesn't perfectly correlate with severity of sleep disorders or likelihood to have a car accident or anything, but it's a good rough sketch, and you can answer these questions, and anything less than 10 is considered normal. You can follow people as you treat them, and you'll often see that the Epworth Sleepiness Score will improve with certain treatments like medications or CPAP for sleep apnea. So you can become sleep deprived and more likely to fall asleep if you have poor quality sleep or you just don't get enough sleep. Quantitative problems, very common in people with shift work disorders, people who have insomnia, certain medical illnesses, particularly things like fibromyalgia, chronic pain syndromes, can cause sleep disruption. Of course, stress and worry can make you not sleep well or sleep very much. And folks with psychiatric problems, particularly hypomania, which is the active part of bipolar disorder, people who are anxious have problems sleeping. Poor quality sleep can be caused by medications, alcohol makes you fall asleep quicker and sleep less well. Certain sleep disorders can cause sleep disruption, such as sleep apnea. We'll talk about that. And people who have poor or irregular sleep schedules. If you don't try to go to sleep at fixed times and wake up at fixed times, you lose some of the circadian pressure that helps you go to sleep and stay asleep. What are the symptoms of sleep deprivation? Increased error rate in complicated tasks. That's a little complicated, but in general, that's true. It can impair your work performance. Mostly sleep deprivation will not hurt you. And there's a lot of concerns. Oh, I didn't sleep enough last night. It's going to be hard on my heart, or it's going to make me get dementia early. I mean, I've heard all of these things, and they're really not true. You feel terrible. You feel anxious. You're irritable. You might have more difficulty maintaining vigilance if you have to do something like driving or running heavy equipment, but it's not going to make you sick. And sometimes the fear of being sick, based on these misunderstandings, can perpetuate insomnias that make the whole thing worse. So it's important to realize that sleep deprivation isn't pleasant, but it's not going to, in the long run, hurt your health much. These were all things that happened around 4 in the morning. somebody shut a valve at 3 Mile Island that should have been open, and they made a mistake when they were performing badly, when they were drowsy at 4 a.m. The Exxon Valdez accident happened around then. The mishaps at Bhopal, where they had the massive poisoning of many unfortunate people and death, and the decision to launch the Space Shuttle Challenger was done in the wee hours of the morning by sleep-deprived people. So big bad things can happen associated with sleep disorders. Well, about 15 years ago, people started saying, we get these doctors and we make them work so long, and they're stumbling around making mistakes all the time, and they're probably killing people and making mistakes and drug errors and all this. And it turns out that's not really entirely correct. And this is a meta-analysis of many, many studies, 873 studies. And in general, I don't like meta-analysis, but they lumped all this together, and they saw that when you have duty hours and you restrict the periods they're at work, they have less emotional exhaustion. They feel a little better. But no one has ever shown that there's a change in hospital length of stay, serious medical errors, medication errors. So it's a little overspoken. And there are other problems with limiting work hours, but they say you cannot train yourself to function better under sleep deprivation, and there are studies that show that. So what the truth is not entirely clear to me, but certainly it's not very nice to be that sleep deprived. When I was an intern, I worked a 30-hour shift every other day, and I felt miserable, but I don't think we were stacking up bodies. So where the truth on that is not entirely worked out. Well, the most common complaint to a general practitioner in their office is one of sleep disorders, and the most common is insomnia. And insomnia is a subjective difficulty initiating or maintaining sleep. About 35% of people say, yeah, at some point or another, I have insomnia. And about 15% say they have it pretty badly. It's more common in women. It's more common in women with children. No one sleeps worse than middle-aged women with children who are working and trying to maintain the house. And I have a whole talk on that if you want me to give that sometime. Insomnia is more common in people who are anxious. The guy who taught me sleep was a brilliant guy, a neurologist, and he used to say that we're all descended from cave people who learned that you really shouldn't sleep when the tiger's outside the cave. So in other words, when we're preoccupied, when we're anxious, we typically don't sleep well. We spend more time in the lighter stages of sleep where it's easier to get woken up. And many people have depression, mostly with insomnia in the early morning hours. There's a whole bunch of different medical disorders that can contribute to insomnia. We talked about mania, bipolar disorder. Drug dependence can affect your sleep. People who drink alcohol fall asleep more quickly, but tend to have arousals later in the night when their alcohol levels drop, and they tend to have less restorative sleep. And alcohol suppresses REM sleep, as do benzodiazepines, certain antihistamines. So all these things affect those things in your sleep architecture. People with psychosis, sometimes it's almost impossible to make them get to go to sleep without very heavy doses of sedation, probably best done in the hospital. Medical disorders can contribute to poor sleeping. People who have difficulty breathing in the first place with COPD or bad reflux. Fibromyalgia causes a lot of arousals throughout the night, many of which you can see on the EEG very nicely. And it's a very hard thing to fix. Neurologic disorders, Parkinsonism is associated with obstructive sleep apnea. Dementia, you often see loss of circadian rhythms and people sundown and interferes with their sleep. fatal familial insomnia. I've never seen a case. It's very rare. These are people who it runs in families and they hit their 30s or so and they develop insomnia. And after about 2 or 3 months of not sleeping, they die. It's a very rare thing. There are circadian rhythm problems that mess up your sleep and can make it seem like you have insomnia because you go to bed when your body temperature is not dropping because the schedule you're on is not the schedule that is in tune with your circadian rhythms. And you see that with shift work, if you travel across time zones, if you have an irregular sleep pattern. Delayed sleep phase syndrome, very common. We'll talk about that in a minute. And then there are some other insomnias. Sleep status perception is very interesting. A lot of people with insomnia have at least a component of this, and you'll put them in the sleep lab and record their EEG and see exactly how much they slept. And then after the test, they say, "Doc, I didn't sleep at all last night," when in fact they slept 90% of the time. And they get very mad when you tell them that. But it is a sleep disorder. Sleep apnea, restless leg parasomnias can also cause insomnia, but it's typically not very common. The people who get insomnia associated with sleep apnea are typically thinner people who have milder insomnia, milder sleep apnea. How do you treat insomnia? I have to tell you, for some reason, the American Association of Sleep Medicine redid the entire classification of insomnias, and now they just call them acute or chronic. And they've taken all these subcategories out, which I find very unhelpful. So when I approach a sleep apnea patient, insomnia patient, I always try to sort out if there's anything else that's driving this. So how do you treat sleep insomnia? Well, you can give people sleeping pills. Sleeping pills give you drug sleep. It's not normal sleep. It affects the sleep architecture. And a lot of them cause a lot of problems. If you stop taking them, you tend to get rebound insomnia. So you take your Ambien every day for a couple of years, then you stop taking the Ambien, and then you don't sleep for 2 or 3 weeks very well. And that tends to get you back on the drug. So that's a problem. And as you get older, these drugs hang around. You don't metabolize them as fast. And they tend to be associated with falls, confusion, dementia. Generally, these drugs should be reserved for mostly short-time use. Non-drug therapies. The most useful thing is something called cognitive behavioral therapy. And if you compare it to medications for insomnia, the people in the group getting the cognitive behavioral therapy have less insomnia after about 6 months than the people who are taking the medications. And it involves relaxation therapy, how to turn off your mind, sleep hygiene, which we'll talk about. And sometimes bright light exposure at particular times of the day can help with insomnia. So what's sleep hygiene? Sleep hygiene are generally some rules for doing things that are more conducive to sleeping, okay? The bedroom should be a place where you only go to sleep, really, or if you're ill. If you're not asleep or in bed ill or something, you really should get out of the bedroom, because if you're not sleeping well and you're in the bedroom, you start to associate the bedroom and everything with it with insomnia and with frustration, and it can over time give you sort of a Pavlovian kind of associative, can't find the word, relationship. So when you go to bed, you get frustrated because the last few nights you went to bed, you didn't sleep, and you associate the bedroom with failure, and you get tense when you go to bed, and this sort of produces a conditioned response. That's what I was looking for, where you get more tense when you go to sleep, and so then you don't sleep, so you get more tense, and it's a big bad circle. So you break that by getting out of the bedroom, going to a different place. You don't want to turn on the computer. You want to turn on the lights or the phone, because The bright full spectrum light, if it hits your retina late at night, will delay your sleep onset. You want to minimize caffeine use, particularly after 2 or 3 in the afternoon. Nicotine is a central nervous system stimulant, and that's not going to help you sleep. Exercising in bright light in the morning, these are some of the Zeitgebers that tend to make you go to sleep earlier in the day and wake up earlier in the morning. So these are things that are generally good to do. Avoiding alcohol before bed is also important. We talked about some of this. I almost never prescribe hypnotics. I do in the setting of transmeridian travel, so people who are flying sometimes benefit from taking a sleeping tablet on the airplane. People with shift work disorder who are on the third shift, sometimes they just can't get to sleep without it. Other circadian rhythm problems that we see, this is probably the most common I see, and I probably see 3 or 4 adolescents a week with this. And they come and they say, Doc, I go to bed at 10, 11 o'clock at night and I can't get to sleep till 2. And I wake up at 9 o'clock and I'm falling asleep in school and I can't get out of bed in the morning. And their circadian rhythm for sleep is moved forward. And when they go to sleep, they have normal sleep. They just wake up very late. And you see this commonly in teenagers who have a tendency to do that. There's some central nervous system that occur when people have this delayed sleep phase syndrome. And it's when you become an adolescent, you have some central nervous system changes that tend to make you have circadian rhythms that shift forward. So instead of your body temperature dropping at 10 o'clock at night, it's dropping at 2 in the morning. So you don't fall asleep till very late. But people view this as insomnia because when they go to bed, they can't sleep. Well, you can't fall asleep if your body temperature is not dropping unless you drug yourself. Advanced sleep phase syndrome is the opposite, more common in older people. They go to bed very early, they go to sleep very early, and they wake up at 3 o'clock in the morning, which is just fine. You know, if you're retired, keep whatever hours you want, but they rattle around pans in the kitchen and stuff, and it upsets people around them. So these are some of the circadian rhythm disorders that can look like insomnia. And people will say, I have insomnia because I wake up at 3 in the morning. Yeah, but you went to bed at 8 at night. Talked about delayed sleep phase syndrome, young people in adolescence, initial insomnia, can't get out of bed in the morning. It causes all sorts of trouble. And people are talking about, oh, you should have school start later in the day. Yeah, that's probably a good point. But you should also not let the kid play with a cell phone in bed till 2 in the morning because the bright full spectrum light from the phone is perpetuating their delayed sleep phase syndrome. These people get better by resetting their circadian rhythms. With selective sleep deprivation, you don't let them nap during the day, you don't let them sleep during the day. If they fall asleep at 2 in the morning and it's 7 in the morning, you make them get out of bed, which increases their sleep pressure and makes them go to sleep at an earlier time. You use melatonin about 6 hours before bedtime in a teeny dose, which is not meant to put people to sleep, but to reset their circadian rhythms. And the best thing you can do is have them exercise with bright light in the morning when they wake up. These are things that the military and NASA use to maintain sleep schedules in places where there's low light or if they want to change a mission time. And this was standard operating procedure on the shuttle because they had all sorts of problems with circadian problems in the early days of the shuttle program. We talked about that. Shift work. Now, a lot of you all work shifts. And when you're younger, it's easier to do it. As you get older, it's more difficult to do and it's more painful. With circadian rhythm, with a shift work, your internal circadian rhythm doesn't match what you're being asked to do at work. They're asking you to be there for the late shift and your body temperature is dropping and you want to go to sleep. It's particularly hard if you change your shifts very quickly, and it's very hard if your shifts don't move forward. So you should work a day, an evening, a night in that order and not move around frequently. And on the days that you're not working, you really need to try to keep the same schedule you're keeping when you're working. It's worse in people working 12-hour shifts, which is very common with our nurses. And it can be quite painful. And then when you get home at 7 in the morning, now you're supposed to go to sleep. Well, your body temperature is rising at that point. How do you get to sleep? So it causes a lot of troubles for people. Some of the things you can do, particularly if you're on the third shift, when you leave home at night. Now, I told you bright light, particularly full spectrum light in the morning, is going to delay your sleep onset. So when you go home, you should wear dark glasses. And this actually was studied using welding glasses. I don't know how anybody could drive a car wearing welding glasses, but wearing dark glasses at work helps. Not having a lot of bright lights on at the end of your shift. Trying to keep the same schedule on your weekends and days when you're not working. Although, that's hard to do when you've got family and kids, household responsibilities. The difference between shift work and travel jet lag is that when you travel to a country, everything is trying to force you into their time zone. Okay, so you're not going to go to sleep in the morning there. You're going to go out and go sightseeing and be out in the sun walking around. When you're doing shift work, everything in your environment is working against your sleep schedule. The phone rings, the kids want something, there's noise in the house. So that makes shift work particularly difficult. So if you get off on the third shift, dark glasses, keep the house quiet. Sometimes taking a hot bath before bedtime helps because then your body temperature drops and it's more likely to make you go to sleep. Don't do anything stressful before bed. Don't turn on the internet, computer, and phones because all that bright full spectrum light will keep you awake. Air raid curtains are helpful. Wear eye shades if you have to. And I give out very few sleeping pills. And sometimes with these people on the third shift, they need something to get them to help them go to sleep. Otherwise, they get terribly sleep deprived. And it's a difficult thing. Now, if you tend to be someone who's a night owl and has circadian rhythms where they tend to want to be awake at night, some people do very well on the third shift. So how badly this bothers you varies depending on your age and your own predilections. And there are some people who are very happily permanent third shift workers and don't mind it. So the most common sleep disorder is sleep apnea. Panos in Latin means to breathe, and a means without. So sleep without breathing. And these are defined as periods of up to 10 seconds where people stop breathing. They can be caused because of an airway obstruction, which is the most common form, where you get some sort of mechanical obstruction of your upper airway. And it can be caused by inability of your brain, brainstem, your pons, your medulla, your thalamus to produce the electrical output to fire your phrenic nerves and make your diaphragm move. So it's either obstructive or you don't have the neurologic drive to breathe properly. Obstructive apnea is much more common. They can sometimes exist together. So obstructive apnea, you get airflow obstruction. Your upper airway is made by the walls of several muscles. And, we talked about REM and atony and losing muscle tone. As you fall asleep, you lose muscle tone in your upper airway. Your upper airway is a tube. And when you breathe in, the pressure in the tube is less than outside, and the airway wants to close. And before it closes, it sort of rattles, and that makes a snoring sound. And if you stop breathing completely, then there's no snoring sound. It's quiet. And instead of dying, the good Lord gave you a reflex, so you wake up, regain your muscle tone, take a breath or two, and go back to sleep. Some people do this very frequently. I've seen 80, 100 times an hour where people will do this, and it interrupts your sleep. you never really get big blocks of interrupted sleep. You get sleep deprived. Your sleep is not refreshing. It's more common in men. It's more common in people who are overweight. It's also common in people with little short chins because they don't have any place to put their tongue. And the tongue doesn't sit flat in the airway. It sits sort of bunched up and closer to the back of their pharynx. Think of Dagwood Bumpstead, those of you who are as old as me. And sometimes you can miss sleep apnea in people like that. People with new onset hypertension who are overweight in males, very likely to get sleep apnea. And people with some upper airway abnormalities, Down syndrome, Pierre-Robin sequence, cleft palates. These folks all tend to get a higher risk of sleep apnea. Alcohol, sleeping pills will worsen this. Even a beer before bed can make people snore worse and have more sleep apnea. Sedating antihistamines, narcotics, benzodiazepines in particular. So you have cessation of airflow and arousal, and you can obstruct anywhere from behind the nose to all the way down to your vocal cords. And when you look at people who are likely to have obstructive sleep apnea and you look in the mouth without having them say, ah, if you can't see anything except for the soft palate all the way down on the base of the tongue, that's somebody who very likely is going to have an airway obstruction. The uvula, which hangs down, can sometimes not be visible. And children with large tonsils can get airway obstruction and large adenoids. I do pediatric sleep and see quite a few children who come in who aren't overweight who have airway obstructions because of this. So when you don't breathe, your carbon dioxide goes up, your oxygen goes down, you have more respiratory drive as your blood becomes more acid, and you have an arousal. There's reflexes through the vagus nerve, and you don't get restorative sleep from it. What are the symptoms of it? Well, sleep disruption, basically. You become excessively sleepy, even though you've slept a long period of time, you're still tired. There's more depression and irritability, learning and memory problems. Some men get impotence. You see more high blood pressure. There's a higher risk of heart attacks and strokes with people with severe sleep apnea. And people have, so that's what kills you in the long run. What kills you in the short run is having car accidents because you're chronically sleep deprived. You have a lot of sleep pressure. And when you go to sleep, it's not volitional. You can just drift into the first stages of sleep and not know it. Most of the time, you can make the history, make the diagnosis with the history. We confirm it by doing sleep tests, and we can use the Epworth Sleepiness Score to kind of help us make the decision about whether someone needs to be studied or not. So I don't know how well this projects. This is a fancy, lovely done polysomnogram. Here you have EEG leads, which can tell you if the patient's awake, asleep, what stage of sleep they're in. You can see if these are eye movement channels, and with rapid eye movement sleep, that's what this is. You see a rapid eye movement. This is an electromyogram, which goes under the chin, and you can look at muscle tone. And this is REM sleep, where there is no muscle tone. And then you get an EKG lead for free. And we can see if you move your legs a lot with these leg leads. And these are respiratory leads. And this is airflow at the mouth and movement of the abdomen and oxygen saturation. And this is a person in REM sleep who is having a decrease in airflow, which we call a hypopnea, which is an apnea is a complete diminution of airflow. This is a reduction in airflow. And there's a corresponding desaturation from about 92 to 89%. And then and the patient does it again over and over all night. This is a home study. This is what we mostly do now. We do this in people we do the polysomnograms in people who have other medical illnesses, who require a more complete evaluation. For people who are just very clearly apneics and you just want to prove it, you can do these home studies. We mail them to people now. They wear them for a couple nights. There are lots of different ways to do that. This is our new system, and it's a particularly nice system. I think it gives a really good picture of things based on older technologies. And you can see here, patient is doesn't really is having a not really. Here's an oxygen desaturation. This is 4 minutes from here to here, so it's all bunched up. But there's a decrease in airflow, which probably represents the hypopnea, and the saturation drops a little bit. You can't see if there's any arousals because there's no EEG. So it's somewhat limited, but it's pretty effective. It's about 1/10 of the cost of doing this. So the insurance companies want us to do it. And you can look at the airflow signals, and you can see here's an obstructive apnea where there's no airflow at all, but the chest continues to move. So the airway's closed, the chest is moving, patient's obstructed their airway, and they can't breathe. With a central apnea, there's no airflow, but there's no movement either. The diaphragm's not contracting. There's no neurologic drive to breathe. The patient has an apnea. Eventually, they start breathing again. A hypopnea is just a decrease in the airflow instead of a complete cessation. So it's all very objective. And there are a lot of things we can tell from a polysomnogram. We can look at the distribution of sleep stages, how many times an hour someone stops breathing, whether their oxygen is going down, whether it's a central or obstructive apnea. And that's important because there are different diseases associated with central apneas. You can grade the severity, and you can see if there are periodic limb movements. Now, the home studies are actually pretty easy to put on. We send them out. There's a YouTube video you can look at it. It's a chest belt and a nasal cannula and a little thing on the finger, and it's really not that difficult. It's a little uncomfortable. It's a little uncomfortable, but it's nothing like an in-lab sleep study, which is quite a deal. I think I'll skip that. So if you have mild sleep apnea, you have 5 to 15 obstructive events an hour. You can normally have up to 5 obstructive events an hour. It's still considered normal. I think the last time I studied myself, I was around 6. Moderate sleep apnea is 15 to 30 times an hour, and severe is greater than 30. I think the worst I ever saw was about 150. And it's interesting. It doesn't correlate with how bad you feel. We see some people who come and just have miserable symptoms. They're dragging around, they're tired, they feel awful, and they stop breathing 8 times an hour. And then we have some people who have just terrible obstructive sleep apnea. You say, oh, there's nothing wrong with me. I feel just fine. And the response to therapy is also variable. So it's a little odd. It's not like most things in medicine where the worse you have it, the worse you feel. So how do you treat it? Well, there may not be any long-term health effects of mild sleep apnea. So you have to have some judgment. And we don't want to put everybody in the world on CPAP. For some people who are mild and don't have symptoms and their oxygen doesn't go down and they don't have comorbid diseases, we'll tell them, why don't you just lose some weight and use decongestants and don't sleep on your back. And often that helps quite a bit. Some people only have sleep apnea on their back. It's like that joke, doc, when I do this, it hurts. Well, don't do it. Well, don't sleep on your back if that's where your apneas are. Easier said than done. It's hard to do that. It's hard to volitionally stay off your back while you're sleeping. So you need something mechanical. I often ask people to wear a fanny pack with some newspaper in it, and that tends to help. Smoking cessation sometimes helps because it decreases upper airway obstruction. If they have allergies, you treat that. All those reasonable things. Sometimes people have badly deviated septums. You can how else can you treat it? Well, in the old days, we just do tracheostomies on everybody, which works great. Not very cosmetic. Once or twice a year, we'll do that on somebody who's critically ill in the ICU, usually several hundred pounds, heart failure, and there's nothing you can really do other than that. CPAP, continuous positive airway pressure, we'll talk about that. That's commonly used in people who are at least moderately severe. Surgery, we've sort of mostly abandoned, except for tonsillectomies and adenoid removal in children. It was done quite a lot when I was younger, and it's sort of not very helpful, and it hurts and costs a lot of money. The new thing is hypoglossal nerve stimulation. I'll talk about that because you see it on the advertisements all the time. CPAP just pressurizes the airway. You know, I told you there's an airway pressure drop in there, makes the airway close. That prevents it. This is a CPAP mask and a CPAP unit, just blows it at constant pressure. We have machines now that adjust the pressure automatically, and it works on almost everybody if you can wear it. About 40% of people can't wear it. I think we do a little better than that in my lab because we really work with people to try to get them compliant. And there's lots of little things you can do to make it better. This is an older CPAP machine. There's many different types of masks and interfaces, probably 30 or 40 on the market. And it's like Coke and Pepsi. Some people like one and some people like another. For people who are mild, particularly if they have a short jaw, the oral appliance, and they don't have a big neck and they're not very, very overweight, the oral appliance is an impression of the upper and lower teeth, and it pulls the lower jaw forward, just like if you were doing CPR and you were doing a jaw thrust. And it moves it a few millimeters, and for some people that works just fine and they don't have to do anything else. You can buy these things on the internet. Please don't do that. They have to really be made by a dentist because there are dental considerations. And if you put pressure on the teeth, they move and you can have problems. So it needs to be done carefully by someone who's trained in it. Surgery, we used to take out the uveal and soft palate. That works great if that's where your obstruction is, but often people obstruct behind the tongue, and you do that operation, and then it doesn't really help anything, and it hurts, and they miss work, and it costs money. So we hardly ever send anyone for one of those anymore. Plus, good Lord gave you your soft palate, so when you drink stuff, it doesn't shoot out your nose. Hypoglossal nerve stimulation, so-called Inspire device. It's for people who are intolerant of CPAP. It's for people with BMIs less than 32, which is a minority of our patients, and with people who have moderate to severe obstructive apnea, so less than, say, so between 15 and 30 an hour. In the big studies, it shows it decreases your apnea-hypopnea index, which is how many obstruction events you have an hour, from 15 to 20 events an hour. So if you start out at 20 events an hour, well, that's great. You're fixed. If you have 85 an hour and you use this and you get down to 65 an hour, you still have big problems. So it's not a complete cure in some people. It does decrease how many times an hour you desaturate. And what it is it's a sensor in the neck that picks up snoring. There's a pacemaker buried in the chest wall here, and it sends a wire up, which is buried under the skin, and is surgically implanted into the hypoglossal nerve in your mouth. And when you start to obstruct your airway, it sends a shock there, which sticks your tongue out. Does it work in some people? Yeah, in selected patients. Is it for everyone? No. It requires 2 episodes of general anesthesia. It's only for people whose airways can obstruct in a certain fashion, laterally rather than anterior-posteriorly, and it costs about $60,000. And you can always get an infected pacemaker pocket. You can break a wire. You can have a battery die. Other side effects of it are listed here. The tongue going in and out all night can get scratched up on your teeth. You get a sensation of your tongue sticking out, occasionally bleeding. Now, this were all in studies that were a few weeks old. I don't know what happens if you stimulate the hypoglossal nerve several hundred times a night over the course of 20 years. I don't know what will happen there. So I almost never recommend this for anybody. Narcolepsy, I'll just mention, it's all the cool disease to have when you're teenagers now. They all want to say they have narcolepsy. I don't understand that, but narcolepsy is a neurologic disorder caused by death of certain brain cells in the lateral hypothalamus that produce a chemical called orexin. And orexin balances histamine in your system, and orexin causes arousal, and histamine causes sleep. And when you lose the arousal input, you start to go to sleep more. It affects about 1 in 2,000 people. It's typically from a viral, and I don't know if that's right. I thought it was less common than that. But it's typically seen in 15 to 30 years old. People become uncontrollably sleepy. They tend to have hallucinations as they fall asleep or wake up. Sometimes they get sleep paralysis where they can't move, and they can get something called cataplexy. And narcolepsy is best thought of as a person who has all the normal stages of sleep but has no control over them. And they can go into any of the stages of sleep during the day, and it's often triggered by things like laughing, anger, and it's a very odd sort of thing. The time to onset of symptoms to diagnosis is on average 8 years, and these people have a terrible time. They're labeled as lazy and malingerers and psychiatric and all this problem, when in fact it's not really so. They just have a neurologic disorder. It's treated with stimulants, and it's treated with antidepressants, which prevent the weak spells or the cataplexy. The trick in treating these people is to balance between alertness and side effects. The medications have side effects, and you want them to be awake, but you don't want them to be sick from the medicine. So it requires careful juggling and several appointments, but we get most of these people feeling a little better. Well, that's the end of my talk. I didn't leave any time for questions. I appreciate being asked to come and present this, and I hope this helps people contribute to their wellness.
Julie, you're muted.
Thank you so much. Sorry about that. Thank you, Dr. Biscardi. I wanted to see if you might have a moment to talk about melatonin.
Sure. Melatonin is a naturally occurring substance which promotes sleep onset. It works in 2 ways. It binds to 2 different types of receptors. One receptor tends to make you go to sleep, and people sometimes take melatonin in large doses before bedtime, which has some sleep promoting effects, but it's not really a great hypnotic when you compare it to things like benzodiazepines. But it does have some effect and is relatively safe. It doesn't affect your sleep architecture much. And it's probably has very minimal toxicity. There's starting to be some reports lately of some problems that occur, particularly in children. You know, in America, we like to get our money's worth. So people, when they go to the store and they see the melatonin, they look at the doses, and this one's 20 milligrams and this one's 2 milligrams. So they get the 20 milligram one. Well, you probably don't need more than 5 milligrams if you're going to use it as a hypnotic. And some people end up taking just whopping doses of this. But it's certainly reasonable to take it. Some people get side effects from it. I had a hallucination after taking it once. It scared me to death. I never took it again. But most people take it without any problems. The other way to take it is to take a teeny dose about 6 hours before your planned bedtime. And that does more to move your circadian rhythms so that you'll fall asleep about 6 hours after you take the medication. got to be a little careful with it. If you take it in the wrong part of the day, it can perpetuate insomnia. So if you want to phase correct someone, you give it to them about 6 hours before bedtime in a teeny dose. If you want to take a bigger dose at bedtime, you can. There are other things you can take that are fairly harmless. Valerian is a herbal medication you can take. It's in sleepy time tea. You can use chamomile. You should not use chamomile if you're pregnant because it might cause spontaneous miscarriages, which I didn't know until recently. But all that stuff's pretty harmless, and you won't get in trouble with any of that.
Thank you so much. I have some people asking if I can share the slides with your permission. I'm happy to share that with it, share those with attendees if that's okay with you.
Sure, I'd be pleased to.
Okay, great. Well, thank you again, and I want to thank all of you all who stuck with us. The majority of people stuck with us till the very end, so kudos to you, Dr. Viscardi. We didn't really have many people drop off, so
Okay.
thanks. And participants, I'll be following up with you within the next week. And everybody have a great afternoon.
Thank you.
Thank you.